So basically the lecture sequence was for Dr. Stravinsky Pereira to talk to you about compressive spinal cord disorders or lesions, and then for me to talk to you about non-compressive spinal cord disorders. And it was very intentionally put in that sequence because we always consider compressive spinal cord disorders before we consider non-compressive spinal cord disorders. Okay. Right, so let's start the lecture. These are your learning outcomes, which is there on your LMS. So we do not need to go through them again. We start with the case history. Can I get one of you to read it out, please, so that others can follow at your timing?
A 26-year-old woman presented with progressive weakness of lower limbs about 2 weeks after recovering from a respiratory tract infection. She has lost bladder and bowel control. On examination, lower limbs were spastic with muscle power 3/5 bilaterally. Tendon reflexes were exaggerated and plantar reflexes were extensor. There was a sensory level at D10. Upper limbs were normal.
Right, thank you. Now, when I give you case histories or anything in the lecture, if there are words that you cannot understand, please ask. If you're shy to ask with verbally, send it in the chat so that I'm sure that you understand what I'm saying. Okay, so any words you don't understand here, you must ask. Okay, so this is the history which you just read out and everybody was following you, I hope. So the question about the diagnosis. Now, you have already learned that a neurological diagnosis has only two components. We need to answer only two questions. That is why neurology is easy. Where is the lesion and what is the lesion? Okay, now from the information that you have, can someone tell me where exactly the lesion is? I have given you adequate information for you to tell me where the lesion is.
The lower thoracic spine.
Lower thoracic spine, good. Anyone else? Anyone else? Have a go, no problem.
T7.
T7 of what?
Vertebra.
Vertebra. Is it in the bone or in the spinal cord itself or in the nerve root?
It's in the spinal cord.
Spinal cord, T7, okay. Anyone else? Any other offers? Any other offers? No other offers? Anyone else? Have a go. So we have two, one saying lower thoracic spine, other one is saying T7 spinal cord.
No sir, T7 vertebra, which means T10 segment.
T7 vertebra. So you mean T10 spinal cord.
Yes sir. Probably one or two segments upper.
That's good. Good to get confused. Okay, so where is the lesion now? Here is the person. And then you see this sensory level. Now this is what is called a sensory level, where there is loss of sensation below this level. Okay, loss of all sensation, pain and temperature below a level. So the first point that you take with you is that if there's a sensory level, it is a spinal cord lesion until proven otherwise. It is not nerve root, it is not peripheral nerve, it is not the brain. Okay, so that's one of the neurology pearls that you have. Okay, so I will be giving you pearls as we go along. And this is one important thing. If you find a sensory level in a patient, it is a spinal cord lesion until proven otherwise. The next thing is to determine what is the level. So if you have a sensory level of T10, now this is not T10 but is shown in the figure. It is showing about T5 level. But if it's T10, like you said, it is about 2 segments. Now don't get yourself confused at vertebral level and spinal cord level. Always refer to the spinal cord level. Okay. So don't worry about the vertebral level. So when you are referring to a lesion, tell us the spinal cord level. So if it's T10, you say, okay, T8 or T10 spinal cord level. We are not too specific as long as you come close to that region. So if it's T10 sensory level, then spinal cord level is T8. So 2 important lessons for you to remember, never to forget, is that a sensory level is spinal cord lesion until proven otherwise. And that level helps you to determine where exactly the lesion is. Now, a spinal cord pathology is called a myelopathy. So this word myelopathy, myelo means spinal cord, pathy means pathology. It's just a broad umbrella term. It has no special other meaning. It just means myelopathy, pathology of the spinal cord, right? Not myopathy. Myopathy is muscle pathology. So this is myelopathy. Now the next question in a neurological diagnosis is, first question, at the beginning of the neurology module, I told you I will make neurology easy for you. So you always approach a diagnosis with these 2 questions, then it is very easy. So now you already have 50% of your diagnosis. You already have made the diagnosis from the information I gave you. You are the ones who told me the answer. I did not tell you the answer. So you already knew this. I'm just emphasizing certain things and reinforcing certain facts. Now our next step in the diagnosis is to try to determine what is causing this lesion at D8 of the spinal cord. Now note, when we say T8, D8, we still mean the thoracic spine. T stands for thoracic, D stands for dorsal. Some people call the thoracic spine dorsal spine, right? So don't get confused. Now let's work out what is the cause of this lesion. Now myelopathies we classify into 2 broad groups, compressive and non-compressive. Now the second most important pearl that I want to convey to you today is that always consider compressive lesion first. Okay. Always consider compressive lesion first. That is why I wanted the neurosurgery lecture before the neurology lecture. Now can someone tell me why am I emphasizing this so much, that always consider compressive lesion first? Anyone? It would have been easier, you would have known the answer to that question had you had the lecture before this.
Because the compressive lesions are common.
It is common, you're correct, but that is not the reason. Anyone else? We don't want only the video people to talk, everybody else listening.
Maybe it could be reversible. And
it could be reversible, very good. You're almost there. You're there, but not exactly there.
So if you treat it by identifying it, prevent.
Good. Still, you're not hitting the nail. You're going around it slightly. Try again. You're there, but not exactly there. Think. Why am I emphasizing it so much? Why am I taking so much time? I say, always consider compressive lesion.
It is treatable.
It is treatable, yes. I agree with you wholeheartedly, 100%. There's something more important than that.
Can be surgically treated?
Yes, that's how we treat it. One more thing. Come on, you all are thinking. So it's treatable, it can be surgically treated.
It's an emergency.
Yes, dear, it is an emergency. That is the name. Why is it an emergency? It's because if you delay, it becomes irreversible. Okay. So compressive lesions are a neurosurgical emergency. If you delay treatment, there would be irreversible loss of neurons and irreversible deficits that we cannot reverse, because you started out saying it's treatable. Yes, everything is treatable, but what we want is for it to reverse. So treatment has to be successful. Need to be treated urgent. So it's a neurosurgical emergency. So that is why we always consider compressive lesion first. Once we get rid of a compressive lesion, so how do we know that it's a compressive lesion? There's only one investigation, the MRI. CT doesn't work, X-ray is not good enough, you have to go for MRI. So if you have a patient with a myelopathy, your investigation of choice is MRI. And it is not to get a date for MRI. You have to do it urgently. So you go and speak to the radiologist and get an urgent MRI done. Okay. Once you have ruled out a compressive lesion, that is when you consider non-compressive lesion. And what I'm going to talk to you today is about non-compressive lesion, and hopefully tomorrow, Dr. Stravinsky Pereira will talk to you about non-compressive lesions. Okay. Right, so how do we classify non-compressive myelopathy? There is a long list, but I have selected the ones that you need to know. And I have classified them based on their pathology. So one is inflammatory, 2 is demyelination, 3 vascular disorders, 4 vasculitis, 5 nutritional, infections, and degenerative. So just 7 topics that you need to know, 7 different mechanisms. And under this mechanism, there are a long list of causes. But for you at the undergraduate level, where as an intern medical officer, you need to know certain etiologies and entities. Those are the ones that I have listed here. Inflammatory, you need to know transverse myelitis. 2 types. One is multiple sclerosis. The other one is NMOSD. What does that stand for? Neuromyelitis optica spectrum disorders. We shall talk about that in a bit more detail. Vascular disorders like anterior spinal artery thrombosis. Vasculitis, your best example would be systemic lupus erythematosus, SLE. Nutritional, like vitamin B12 deficiency. And these 2 infections, HIV, syphilis keeps re-emerging, and we do encounter it again and again. And finally, degenerative causes like motor neuron disease, which I shall have a lecture tomorrow for you. Motor neuron disease, tomorrow at 3:15, I'm doing a lecture for you. Remember, there's a change in the timetable. So tomorrow, I'm doing the lecture on motor neuron disease for you at 3:50. And then syringomyeloid. So these are the 7 different mechanisms, and under those mechanisms, I have selected the most important entities that you need to know, right? So all for your convenience. So let's start with transverse myelitis. What is transverse myelitis? Now transverse means going across. Myelo means spinal cord. Itis means inflammation. You already know this. So inflammation that goes right across the spinal cord is called transverse myelitis. So the term describes what the pathology is. So, and it is an acute inflammation. We do not talk about subacute and chronic inflammation. We are talking about acute inflammation of the spinal cord that goes right across. Usually restricted to 1 to 2 segments in the thoracic cord. So if it's acute, the symptoms develop over a few hours. And the patient reaches maximum deficit within 24 hours. So here is a patient who, example, if I give you an anecdote, young person, this 26-year-old person wakes up in the morning and finds a little tingling in the lower limbs. By about 9, 10 o'clock, there is a little hirivatilla vadivela, more numbness in the feet. And then by about 12 o'clock, finds it difficult to walk, but still is able to walk holding to objects. Then by about 3 o'clock in the afternoon, sits on a chair but cannot get up. And then by about 5 o'clock, cannot walk at all. So that is the usual progression. Within 24 hours, it has reached its maximum where the person goes off legs. So that's a transverse myelitis. And the pathology you already know, it's an acute inflammation that goes right across the spinal cord. I have listed there for you. It is in the thoracic cord, about 1 to 2 seconds. So if there's inflammation of the spinal cord, then you lose function below that level of everything. So what is everything that goes down the spinal cord? You have learned in your anatomy and physiology. There is motor function. So you will lose all motor ability. So that is why there is paralysis. So if the inflammation is in the cervical cord, you will have quadriparesis. If the inflammation is in the thoracic cord, you will have paraparesis. Okay, that's easy. And the sensory will depend again on the level of the lesion, where the sensory level is. And as I told you, always spinal cord lesions, you need to consider BBS, not Bodubalasena, bladder, bowel, sexual function. Okay, similar to Bodubalasena, but it is different, slightly different. Right, BBS, bladder, bowel, sexual function. So sphincter function below the lesion. Okay, so I told you the investigation of choice is this. Patient has come. We have done an MRI. Now, can someone tell me what is different between A and B? If you remember when you were in grade 5 or so, there are these pictures. A, B, atara venaskam pahak kiyanna. Then you get a little prize. So what are the difference? These are the same patient at the same time. We have done an MRI. What is the difference between A and B? A is on the left, B is on your right. Anyone? Can you see any abnormality? Can you see that? Okay. Can you see that, everybody? So you see those lesions there. This is the same patient, right? You see this whitish lesion. Now the spinal cord on MRI appears gray in color. These are the vertebral bodies that you see. These are the intervertebral discs. Can you see my cursor? Yes?
Yes.
Right. So you can see the spinal cord, follow the cursor, and these arrows are showing you the lesions. Can you see these whitish lesions? Now, why is it different between A and B? The difference is it's contrast enhanced. Now, I have told you this before several times when we did about the infection, CNS infections, when we did about TB. If you are looking for infection, inflammation, or tumors, you must always give contrast. Now, you can see this is the same patient done at the same time, how easy it is to miss the lesion. Do you agree? If you were given A, you would have passed the spinal cord as normal. If the minute you give contrast, you can see the contrast enhancing lesions. If you do not give contrast, you do not see any enhancement and you can easily miss the lesion. So your next pearl, neurology pearl to remember is that this, I have told you before in every lecture, if you are looking for infection, inflammation, tumor, right? Neoplastic lesions, you always give contrast. Now, if you do not ask for contrast, the radiographer will not give contrast. So what are the causes of transverse myelitis? One is idiopathic. Idiopathic means no one knows. Very easy. Second, of course, is most common cause are infections. So I have listed some of the common infections. Epstein-Barr virus, cytomegalovirus, varicella zoster virus, rabies, mycoplasma. Mycoplasma is a bacteria or a virus?
Bacteria.
Good. Then there are post-infectious causes, meaning you get the infection and the transverse myelitis comes several days or weeks later. So the infection has come and gone, but it is the body's immune system that responded to the infection that causes the transverse myelitis. So some of these infections that evoke a post-infection immune transverse myelitis, I have listed there, like influenza, measles, varicella, and your beloved COVID-19. Okay. So this COVID-19 will start appearing all over your nervous system. When we talk about encephalitis, also we talk about COVID-19. When we talk about demyelination, we talk about COVID-19. When we talk about transverse myelitis, we talk about COVID-19. We talk about Guillain-Barré syndrome, we talk about COVID-19. So your COVID-19 is so much in love with you that it will keep reappearing again and again when we go through this nervous system. Okay. Right, so that's all I want to tell you about transverse myelitis. I hope I am clear. Please, 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 if you are not clear on anything, stop and ask. And if you are ask, just send a chat. Okay, ask.
Sir, post-infectious means does the immune response in body is the cause?
Say again.
In post-infectious causes, is the virus or the bacteria itself cause it, or the immune response to the body cause?
The immune response. Now here, these are infections, means the viruses or the bacteria directly has an effect on the spinal cord. Okay. These are what we call neurotropic viruses. They have an affiliation towards the neurons, so they go and infect the neurons. Herpes viruses are well known for that. Okay. Post-infectious it is not the infection that causes it. The infection evokes an immune response. And it is the immune response that causes the inflammation. So if you go to the spinal cord, say the patient dies, we dissect the patient's spinal cord, we are not going to find any viruses. The viruses have come and gone. They are not there. Okay. Is that clear?
Yes, sir.
Right, let's move. Multiple sclerosis. Multiple sclerosis. Now, each word here that I have listed is so important. You need to follow me. Multifocal. What does that mean? Multifocal means multiple sites in the nervous system. Multifocal, multiple sites. Inflammatory tells you what is the pathogenesis. It's an inflammation. What does the inflammation cause? Demyelination. You know, all nerves are myelinated. So this inflammation leads to demyelination. Where? In the central nervous system, not the peripheral nervous system. When we say central nervous system, brain and spinal cord, right? The optic nerves are an extension of the central nervous system. They are not part of the peripheral nervous system. They are central nervous system. Okay. So let's go through these words again. Multifocal, that means multiple sites in the CNS, where there is inflammation that leads to demyelination. So if focal inflammatory demyelination in the CNS is what multiple sclerosis is. Is that good enough to know about multiple sclerosis? No, you need to know something more. What is that? There has to be dissemination in time and space. What does that mean? Dissemination in time means that you get two different lesions at two different times. Right? Space doesn't mean the space as space. It means in the central nervous system. So for example, someone gets a transverse, gets better in a few weeks, and then about 3 weeks later develops an optic neuritis. So that is dissemination in space, that means different site of the central nervous system, or develops a cerebellar ataxia. So gets a spinal cord lesion, myelopathy, that myelitis improves. Then the patient, about a month later, comes to you with the ataxia. So that is multifocal, disseminated in time and space, two different sites in the central nervous system at different times. Now, multiple sclerosis, the majority of patients are relapsing and remitting. What does that mean? They have relapses, they get better, then they get another relapse, which this diagram shows you beautifully, right? So this is something I drawn for you. So this is a relapse. Now this is the clinical threshold. Now there is inflammation that is occurring below the clinical threshold that is not clinically apparent. We cannot see that to the outside. But when it goes beyond this threshold, then it manifests. Say a patient develops a hemiparesis. because of a lesion in the brain. So if there's a left-sided lesion, right-sided hemiparesis, then that completely resolves. The patient becomes completely normal. And then a few weeks or months later, develops paraparesis. That is because of a lesion in the spinal cord. Now, that is what we mean by relapsing and remitting. Remitting means normal. On this axis is what? So that is a relapsing remitting. But as the patient gets relapses and remissions, there is an accrual. That means a accumulation of neuronal damage, axonal loss. So that when these relapses become more frequent or late in the disease, they do not return to complete normality. There is a little bit of disability. Then with the next relapse, the disability accumulates. And there's a progressive increase in disability. And after beyond one point, then you hardly see these relapses, it just progresses. What we call SPMS, so a relapsing remitting multiple sclerosis, becomes secondary progressive multiple sclerosis. Is that understood? So the majority of patients, it is relapsing remitting multiple sclerosis. Over 80% of patients. A proportion of them, as time goes by, these patients will then develop secondary progressive multiple sclerosis. So what is the pathophysiology of multiple sclerosis? No one knows what causes multiple sclerosis. There are a few genetic HLA associations and predispositions. And there are hypotheses that viruses may trigger this, but no one exactly knows what causes multiple sclerosis. It's an autoimmune condition. It is an autoimmune condition that evokes an inflammatory response. So it's an autoimmune inflammatory disorder. What does that inflammation lead to? Inflammation leads to demyelination. And as you get this demyelination, it can continue on a clinically, you can get relapses, or when it's subclinical, it will continue to have axonal degeneration. So whether it's clinically apparent or inapparent, there will be continued axonal degeneration. So there's progressive axonal degeneration. So even if the patient is normal, within the body, within the central nervous system, with time there's a continued loss of axons. And at one point that is going to manifest clinically. Now, if you look at the histology, if you take one of these lesions and look under a microscope, you will see a lot of inflammatory cells. What are these cells? You have T cells, you have B cells, you have macrophages, and you have demyelination and remyelination. So you have this remyelination also occurring, and also you will have axonal degeneration. So you have the demyelination, you have the axonal degeneration. Now the thing with demyelination is it can remyelinate. But if you lose axons, they don't get replaced. As you know, the nervous system doesn't replace itself. So what have I described here? What have I described here? Cell-mediated immunity or humoral immunity. Anyone?
Cell-mediated?
It is cell-mediated immunity. So remember, multiple sclerosis is predominantly driven by cell-mediated immunity. And the lesion that we see in the central nervous system has a special name that we call it. We call it demyelinating plaques. And that is what we see. We can see it on imaging, these demyelinating plaques. So get used to this terminology. So in multiple sclerosis, we refer to demyelinating plaques occurring in the central nervous system. They never occur in the peripheral nervous system. And I told you they are disseminated in time, meaning they occur at different time points. And they're disseminated in space, meaning they occur in different sites of the central nervous system. And that there is a progressive axonal degeneration, which time there is atrophy, there is loss of neurons. And therefore there will be accumulation of disability. So those are the hallmarks of multiple sclerosis. So these demyelinating plaques, the pathology, the hallmark pathology of multiple sclerosis have some favorite sites in the brain. Not in the brain, in the central nervous system. So what are these favorite sites? One is the optic nerve. I told you this is autoimmune inflammation. Autoimmune inflammation. So it is going to be itis. So when it affects the optic nerve, you get optic neuritis. Then the next favorite site, there are only 4 favorite sites. Next favorite site is the brainstem. So you get cranial nerve pulses. In the cerebellum, you have ataxia and incoordination. So the patient will present with a cerebellar ataxia. And finally, spinal cord transverse myelopathy. So that is why we are talking about multiple sclerosis under the topic of non-compressive myelopathies, because it causes transverse myelopathy. So these are the 4 sites I want you to remember: causing optic neuritis, cranial nerve pulses, ataxia or incoordination, and transverse myelitis. Who gets multiple sclerosis? Old people or young people? It is young people. Any autoimmune disease is more common in men or women? In women, right? So it's autoimmune disease. And the peak incidence is 30s and 40s, but we see patients from the age of 20. And we also see in pediatric multiple sclerosis is also well described. This is a disease of young people, and it don't kill people. So it goes on for years and years. It disables people. So it is the young working workforce or people who are carrying the burden of society or burden of the family. Young women who are married and looking after the family, looking after children are affected from this. So it's a huge problem. The incidence is higher with increasing latitude. What is latitude? A laid back attitude. What is latitude? Anyone? Hello? What is latitude? I told you if you don't understand, you must ask. What is latitude? Hello?
The horizontal lines in the world map.
Horizontal lines in the?
World map, they help to tell
In the
the
world map. How does that translate to real life then?
when you go away from the equator, the incidence increases.
So Akshansha the Deshansha. Akshansha or Deshansha?
Akshansha.
Akshansha, yeah. So as you go away from the equator towards more temperate countries, it becomes more and more common. That doesn't mean it is not common in this part of the world. Now, for example, when we work in England on a clinic day, we are guaranteed to see about 2 or 3 patients with multiple sclerosis coming to clinic. In Sri Lanka, we don't see as many, but we see perhaps at least 1 per month or 2 per month with multiple sclerosis. So the incidence is less when we are close to the tropics, close to the equator. As you go away, north and south. So north is towards the European countries, south towards Australia, New Zealand, South Africa, then you're going to see a lot of multiple sclerosis. Why that is, no one really knows. They think, they are postulating, hypothesize that certain viruses may trigger it and they are more common in those colder countries. How do you diagnose multiple sclerosis? I told you the key features. You have to demonstrate dissemination in time and space, either clinically or on MRI. So say a patient comes with transverse myelitis, we know already the spinal cord is affected. But if we do the MRI and we find lesions in the brain, then we know there are 2 sites involved. So we have already demonstrated dissemination in space, right? And then if the lesions in the brain are old and the patient has come with a transverse myelitis, we have already demonstrated dissemination in time. So that is, even with the first presentation, you can diagnose multiple sclerosis. And then this important fact that you must remember is that in multiple sclerosis, the brain MRI is positive in over 90% of patients, right? So even if the patient comes with a transverse myelitis, You always do a brain MRI. Sometimes the patient asks, I may always scan එකක් කරන්න. මගේ ඔළුවේ ප්‍රශ්නයක් නැහැ. But you are looking at the brain because you are thinking of the possibility of multiple sclerosis, especially in a young person, male or female. Obviously, it's more common in women, but that doesn't mean males are not affected, right? So when males or females, young person coming with a transverse myelitis, in addition to the spinal cord to diagnose the lesion, looking for a etiology, we also do a MRI of the brain, because we know in multiple sclerosis, the brain MRI is positive in over 90% of patients. In the CSF, we look for what is called an oligoclonal band. That means an increased production of IgG in the CSF, which we can look electrochemically. And then we look for visual evoked potentials. Visual evoked potential, when you are doing your neurology rotation, clinical rotation, please go to the neurophysiology department, speak to Dr. Sudat Gunasekara, ask him to show you a visual evoked potential, how they do it. And that is how we diagnose optic neuritis, old optic neuritis, because optic neuritis can be subclinical. The patient never realized that the patient had optic neuritis. And when there is optic neuritis, present with optic neuritis, that is obvious, because the patient will say, I can't see in one eye. I have pain behind the eye, doctor. You don't need to do a VEP. Here's a patient coming with transverse myelitis. You want to demonstrate dissemination in time. So you are looking for an old optic neuritis. So you do a visual evoked potential. Patient presenting with optic neuritis, you don't do VEP because it's obvious. Now this is the MRI that I was talking to you about. Now the normal, can you see my cursor? The brain is the normal, healthy brain is gray color. There are my cursors. Now these are the typical demyelinating plaques. They have some very typical characteristics. What are the characteristics? They love this periventricular region. Now you can see the ventricles here. They are in the periventricular region. Can you see those? And these demyelinating plaques are ovoid in shape, oval shape. They are not rounded, they are oval. Can you see oval? And they are perpendicular to the long axis of the ventricle. Now this is the long axis of the ventricle. And these are perpendicular to the long axis of the ventricle. So this is very typical MRI. Now when we see this, we know it is MS. Okay. That is in the axial section. Now if you look at the sagittal section, you can see this oval shape demyelinating plaques, multiple of them. And what do you see here? You see the corpus callosum. And on the corpus callosum, it is like fingers, isn't it? Fingers sticking out of the corpus callosum. These are called Dawson's fingers. Dawson, D-A-W-S-O-N. Dawson's fingers. That is the man who described it. Not that his fingers are there. These are the Dawson's fingers, typical that you see sticking out from the corpus callosum when you look in a sagittal plane. Okay. Now, when you look at this MRI, is there dissemination in space? Anyone? You all must talk. It's very boring for me to lecture to a screen if you do not talk. One thing for you all to switch your videos on it. I'm not asking you a specific question. I'm just asking you what you see. So I'm asking you, is there any dissemination in space that you see on this MRI?
The cerebellum?
Yes, excellent. You see this cerebellar lesion. So clearly there's dissemination in space because there are lesions in the cerebral cortex, subcortical white matter. Also you're seeing the lesion in the cerebellum. So there's already you're demonstrating dissemination in space. Now how do you know dissemination in time? If you give contrast, the acute lesions will enhance, whereas the chronic lesions won't enhance. So that is why, if you remember when I started the lecture, I said always in inflammation, infection and neoplasia, we give contrast. So here in multiple sclerosis, it has a special significance because the new lesions will enhance. The old lesions won't enhance. So if you have enhancing lesions and unenhancing lesions, then you already have dissemination in time. So you fulfill both the criteria and you have the diagnosis. Okay. How do you treat? For acute demyelination, patient comes say with transverse myelitis or optic neuritis or cerebellitis. With the acute demyelinating plaque, the treatment is high dose intravenous steroids. So we give methylprednisolone 1000 milligram per day for 3 to 5 days. And the patient, there is a remarkable improvement because the inflammation reduces and the patient improves. I told you it is a progressive disease. Although you do not see relapses, underneath in the central nervous system, there's a progressive axonal degeneration. So we have to prevent the accumulation of neuronal loss. So for that, we use disease-modifying treatment. So what are the disease-modifying treatments that we use? We have injectables, called interferon beta, glatiramer. We have infusions like nacrelizumab, alemtuzumab, mitoxantrone, rituximab. We have oral ones like dimethylfumarate, teriflunomide, and fingolimab. Are these medications available in Sri Lanka? Yes, we have interferon beta, we have mitoxantrone, we have rituximab, we have natalizumab, we have alemtuzumab. Do we have teriflunomide? Yes. Do we have fingolimab? Yes. Now, at undergraduate level, we are not going to ask you this. So why am I teaching you this? Anyone? If you notice, throughout this neurology module, I am selecting and giving you the essential core. Why am I now teaching you something outside the core? It is because even though we don't ask you this, you're bound to see patients on this medication. And when you see this medication, you won't know what the hell is this medication? Why is this given? So that is why I have given it to you so that Sunday it will strike your head. This medication is given for multiple sclerosis as a disease-modifying drug. So then you can go back to your notes and look at it and make sense out of it. So that is why certain things we teach you is because it's practice-based. It's very important. There are many patients, young people walking around who are on these medications. Okay. So you must know the basis of this medication. We are giving disease-modifying treatment to prevent the accumulation of disability. Okay. And then what is the prognosis? Over a period of time, if you do not treat adequately, there would be quite significant disability. And there is more and more evidence coming from lots of research because multiple sclerosis is an area that is highly researched. Can you tell me why? I already told. You just have to tell me back. Why is there so much research, so much money put into multiple sclerosis?
No etiology has been found. Because the etiology is not completely understood.
No, but who is giving the money?
The pharmacy.
Pharmacy then. Who is giving the money? Why is this? I mean, do we get people doing enormous research on, like diseases we find here?
It is more prevalent in which countries?
Yes, exactly. It is a big problem in Western countries. I just told you when I work in England, I see three to four patients a day. It's a huge problem in Western countries that have money. So they put all their money trying to solve this problem. So there are more and more medication coming into the picture, more and more research being done. And what they have found is that early immunotherapy, when we were students, when we were, registrars, house officers, we used to start treatment for multiple sclerosis only if they develop the second relapse. Now we start treating as soon as the patient presents with the first symptom. Because the earlier you treat, the more neurons you preserve and less long-term disability that you have. Okay. So if you treat, you don't get this amount of disability that occurs over a period of time. Okay, let's move on to the next thing called neuromyelitis optica spectrum disorder. Now, what is the importance of this classification? Why do you need to memorize this classification? Because if you memorize this, already you know neuromyelitis optica is a demyelinating disease. Because it comes under the classification of demyelination. That's the whole purpose I told you. Classification should be simple and pragmatic. So you know that it is a demyelinating disease. It's not a vascular disorder. It's not a vasculitis. It's not a nutritional problem. Okay. Right. So neuromyelitis optica spectrum disorders. The term is like multiple sclerosis, very explanative. Neuromyelitis. Myelitis means inflammation of the spinal cord. Optica means optic neuritis. So you have spinal cord and optic nerve inflammation. That is the majority of patients. Why is it called spectrum disorders? Because there are certain neuromyelitis optica spectrum disorders where you don't get optic neuritis or myelitis. You might get just, refractory vomiting or a condition called area post-rheuma syndrome. But don't worry about that. We worry only about the most common presentation. It is an astrocytopathy. Now that we can ask in a multiple choice question that I will ask you. So better remember that. What do you mean by astrocytopathy? It is a problem with the astrocytes in the central nervous system. It's a pathology of the astrocytes caused by autoantibodies directed against aquaporin 4. What is aquaporin 4? Aquaporin 4 is the most abundant water channel in the central nervous system. Okay, it's a water channel on the cells in the central nervous system. It is the most abundant. And it is found on the astrocyte food processes. So there are autoantibodies. Now, what is the immunity in multiple sclerosis? Now, these are two demyelinating diseases that are very similar to each other. Why? Multiple sclerosis also can present with transverse myelitis and optic neuritis. Neuromyelitis optica also presents with transverse myelitis and optic neuritis. You need to differentiate the two. So first and foremost is to understand the pathology, the difference in pathology of these two conditions, right? Neuromyelitis optica is the astrocytopathy caused by autoantibodies. So what was the immunity in multiple sclerosis? Cell-mediated or humoral?
Cell-mediated.
Good. And in neuromyelitis optica?
Antibody-mediated.
It is humoral. It's antibodies. So there is an essential difference between the two, right? Absolutely essential. Here the antibodies, the MCQ is neuromyelitis optica is caused by aquaporin 4 autoantibodies. Answer is true. It typically presents with recurrent optic neuritis and longitudinally extensive transverse myelitis. So that is a term you have to learn. LETL, longitudinally extensive transverse myelitis. So that is one essential difference how we differentiate with multiple sclerosis. Here in multiple sclerosis, the demyelinating plaque is only about 1 to 2 segments of the vertebra. If you take the vertebra, the length of the lesion is short. They are short lesions. Whereas in NMO, they are long lesions. Can you see they start somewhere here in the brainstem, goes right along to this level in the cervical cord. Okay. So what is the definition when you say longitudinally extensive? It is more than 3 bodies of vertebra. So can you count the vertebra? This is the dens. So 1, 2, 3, almost 4 vertebral body heights. So the definition is more than 3 vertebral body heights. So it's longitudinally extensive transverse myelitis. So that's how you differentiate with MS. And the other difference with MS is in neuromyelitis optica, you don't get those typical lesions you see in MS, in the brain. I showed you those doors and fingers, demyelinating plaques in the brain, in the periventricular region. You don't get in NMO. Okay. Now there's also an essential difference between NMO and MS. I told you in MS there is a progressive axonal degeneration or loss even when the patient is well. Whereas in neuromyelitis optica, the disability is related to relapses, meaning between relapses there is no axonal loss. Okay. So if you prevent the relapses, there is no accumulation of disability. So the patient presents the first time and you prevent the patient from ever getting a relapse again, there won't be any other disability. The disability will be only the presentation. And if that completely recovers, then there is no disability. Understood? So that's the essential difference between NMO and MS. So MS, the disability is related to relapses. Whereas in MS, even during remission, there is progression of disease. Okay, brain MRI I told you, usually non-diagnostic for MS. That means you don't get those demyelinating plaques that you see in MS, in NMO. You get this aquaporin 4 IgG antibodies detected in the serum and CSF. Serum is more sensitive than CSF. Now, why is it important to differentiate NMO from MS is because in NMO, if you don't diagnose NMO properly and you think it is multiple sclerosis and use the treatment like interferon and fingolimod, it worsens NMO. You get more and more relapses, and that those relapses will cause irreversible disability. Treatment we use is immunosuppression. Okay, so we finished the management. That's all I want to tell you about NMO, and I hope I have clarified the difference between MS and NMO. Now we go to vascular disorders. This is just very simple, anterior spinal artery thrombosis, because this you already know. This is purely anatomy. This is the vascular blood supply of the spinal cord. The posterior 1/3 is supplied by 2 posterior spinal arteries. The anterior 2/3 of the spinal cord is supplied by 1 anterior spinal artery. So there are 2 posterior spinal arteries, but 1 anterior spinal artery which supplies anterior 2/3 of the spinal cord. I have told you before, vascular disease, vascular causes a sudden onset. If I put it another way, sudden onset neurological deficit is avascular unless proven otherwise. Okay. Sudden onset neurological deficit is a vascular etiology unless proven otherwise. So you are expecting, if you think it is, if you are going to say this is anterior spinal artery thrombosis, the onset needs to be sudden. Right. What are the neurological deficits in anterior spinal artery thrombosis? What would be the clinical presentation? If you remember your anatomy, here are the lateral corticospinal tracts, here are the lateral spinothalamic tracts. The corticospinal tracts are the ones that takes your motor function, pyramidal fibers. Here are the lateral spinothalamic tracts, which are the ascending sensory fibers. The dorsal columns, which is your fasciculus gracilis and fasciculus cuneatus, which takes proprioception, are not affected because it is the anterior 2/3 of the spinal cord that are affected. So when the corticospinal tracts are affected, you have spastic paraparesis, apomotor neuron spastic paraparesis. When you have the lateral spinothalamic tract affected, you have loss of pain and temperature. So you have a sensory level with spastic paraparesis below a sensory level. However, the proprioception is spared. So although the patient has spastic paraparesis with a sensory level, if you test the joint position sense, that is spared. So that is your next pearl, neurological pearl. Are you with me? Always, always. In a patient who comes with spastic paraparesis and sensory levels, you must always examine the proprioception, the joint position sense. It's a big miss if you do not examine joint position sense. So when you come for the final MBBS short case, you have a patient with spastic paraparesis and a sensory level, and you say, sorry sir, I forgot to test the JPS. What do you think we feel like? We feel like you have not understood or appreciated the importance of the JPS. Because a good student, the minute you get the sensory level and the spastic paraparesis, would always consider the possibility of anterior spinal artery thrombosis and would consciously, carefully look for JPS. Okay, so very important. Right, let's move on. Vasculitis. You will learn SLE under rheumatology. So we will move on to vitamin B12 deficiency. Right, vitamin B12, a vitamin, causes subacute combined degeneration of the cord, also known as SACD. What is Subacute means not acute, not chronic. It's in between. Okay, over several weeks, days to weeks. What do you mean by combined? Combined means 2 or more. Degeneration of the cord. So there are several structures in the spinal cord that are affected over a subacute period, and that results in certain clinical manifestations. Now, this is the typical profile of a B12 deficiency, which is exaggerated knee jerks, but absent ankle jerks. Knee jerks are brisk, ankle jerks are absent. Then again, when you test the plantar response, it is extensor, Babinski positive. Then when you do the sensory system, there's sensory loss, stocking sensory loss. What do you mean by stocking? It's like your socks, when you wear your sock, just a stocking sensory loss, that distribution. And there's lots of JPS, joint position sense, which I told you, you must always examine in every patient. Okay. So these are the typical clinical manifestations. Now, again and again in lectures, I'm telling you, I'm a clinician, I'm telling you, there is no point memorizing this and answering it at NCQ or SCQ. If you cannot elicit this consciously in your mind, going through this in a patient. A patient won't come and say, doctor, mata B12 deficiency. Mata tino SCCD kila takya. He's not going to come and tell you. Patient is only going to tell you, doctor, I have difficulty walking. That's all. Or the patient will come and say, mage kakul hiri vetila doctor. That's all. It is you who will consider this as a differential diagnosis and try to elicit these signs. So please do not limit your knowledge to a piece of paper or exam, because all this learning is what we are teaching you, what I am teaching you. I am preparing you for the final MBBS exam, in other words. Because we give you enough and more patients with B12 deficiency at the exam. Okay. With these physical signs. And the only instruction is, patient has difficulty walking, please examine the lower limbs. That's it. And you can, if you elicit all these signs, then you elicit these signs and you smile, have a laugh and say, my diagnosis is subacute combined degeneration. Your question is, which structures of the nervous system are involved to manifest, to present these clinical features? Now let's go back to anatomy. So when you say subacute combined degeneration, now here is a cartoon of the spinal cord. Again, I'm showing you the dorsal columns, the gray matter here, then dorsal nerve root, the ventral nerve root, the ganglion there, dorsal root ganglion, and the peripheral nerves, spinal nerves. Okay. You will have your lateral corticospinal tract there and the spinothalamic tract there. Okay. So what happens in subacute combined degeneration means, subacute is the timing, that is it occurs subacutely. Combined means more than one. What are the two sides? One is the dorsal column. There is a lesion in the dorsal column. There is also a lesion in the lateral column. So here the dorsal columns are affected as well as the lateral column in the corticospinal tract. So that is why it's called combined, and there's degeneration of these tracts. There's degeneration of the dorsal columns, there's degeneration of the lateral. In addition, there's also damage to the peripheral spinal nerve root. So there are three sites that are involved. So let's try to work out the clinical manifestation based on anatomy and physiology. So why would you get exaggerated knee jerks? Because the corticospinal tract is affected. Okay. Why would you get absent ankle jerks? Because the peripheral nerve is affected. So although the corticospinal tract is affected and would cause exaggerated ankle jerks, the art is lost in the ankle jerks, where it's the most peripheral nerves that are affected. Extensor plantar responses because the corticospinal. Stocking sensory loss because the peripheral nerve. And joint position sense is lost because of the dorsal columns affected. So you can work it out anatomically, or if you remember the anatomy, then you can work out the clinical manifestations of subacute combined degeneration of the cord. So what is combined? The dorsal columns and the lateral columns undergo degeneration. And why is that? Because vitamin B12 deficiency. Why in vitamin B12 do you get loss of neurons? Because vitamin B12 is an important, a crucial coenzyme in transmethylation, which is important for DNA synthesis and myelin basic protein synthesis. So if you don't have DNA and you don't have myelin basic protein, then you're going to get degeneration of the neurons. That is why. That is what is so magic about vitamin B12. Okay. Pure vegetarians, vegans who do not take any milk, fish, meat, or eggs, please don't start eating those again. If you're a vegetarian, remain vegetarian because that's a good thing. But if you're pure vegan, then get a B12 injection, right? If you're not pure vegan, then taking milk and eggs would suffice because that will give you B12, animal source of B12. The other way is to take supplemental oral B12 tablets. What are the other features of B12 deficiency? If we are suspecting subacute combined degeneration, then we are also looking for blood involvement. You know, with B12 deficiency, you will have macrocytic megaloblastic anemia. With B12 deficiency, you develop dementia. You remember the dementia lecture? Memory disorders? I gave you a reversible cause of memory disorder is B12 deficiency. Please go back to the lecture. If you can't remember that lecture, that means you have dementia. Okay? Because that lecture was just done a few days ago. So if you can't remember that, that means major problem with dementia, right? And then the other thing is optic atrophy, and that is the question we will ask you when a patient, now with great difficulty, you diagnose subacute combined degeneration of the cord at the final MBBS short case, and you say, this is a subacute combined degeneration causing B12 deficiency. B12 is important in transmethylation and DNA synthesis. And then we ask, what cranial nerve would you examine? What examination would you do in the cranial nerves? And the answer we expect is fundoscopy. Looking for what? Optic atrophy. Okay, let's move. So we have ended the lecture. Question 26. This is the case history we started with. 26-year-old woman presented with progressive weakness of lower limbs about 2 weeks after recovering from a respiratory tract infection. She lost bladder and bowel control. On examination, lower limbs were spastic with muscle power 3 out of 5 bilaterally. Tendon reflexes were exaggerated and plantar reflexes were extensor. There was a sensory level at detail. Upper limbs were normal. MRI ruled out a compressive lesion because I said we first always consider what is diagnosis. So transverse absolutely correct. Well done. Go through that list. I have given you 7 there. 7 pathological mechanisms and the classical example under each. Go through that list and tell me what else can it be.
Neuromyelitis optica.
Good. Possible. Why not?
Multiple sclerosis.
Multiple sclerosis. Why would you say neuromyelitis of multiple sclerosis? Why multiple sclerosis? Anything in the history? Anything in the history that would make you suspect this could be multiple sclerosis?
Spastic lesion.
No,
Spastic lesion.
Spastic hameke mein no anidaru. Transverse myelitis. Anything in the history that suggests that this could be multiple sclerosis? Anyone?
Young woman.
Exactly, young woman. That is why it is so important to learn epidemiology. That is why we keep telling you which age group, which sex it affects. Because when you see a patient, you can narrow down your differential diagnosis based on the age and sex of the patient. So any young person coming, whether it's man or woman it is more likely that you must always consider demyelinating cause. So post-infectious transverse myelitis, because the infection had occurred, respiratory tract infection 2 weeks ago, after 2 weeks after recovering from a respiratory tract infection. So it is not a infectious transverse myelitis, it is a post-infection. Or it's a first episode of multiple sclerosis or neuromyelitis optica spectrum disorder. So please, every time you get a patient, go through the 7 categories I have given you. Understood? Don't just jump into one. Consider each one. Can it be transverse myelitis? Could it be a demyelinating disease? Could it be a vascular disease? Could it be a vasculitis? Could it be a degenerative disease? Could it be infectious disease? Could it be a B12 deficiency? Go through each one of those. That way you will not miss. If you try to guess and jump into one, you are going to miss a lot. Now here you, at the exam also, you will say transverse myelitis and keep looking. What is the differential diagnosis? Don't. So if you go through the 7, you immediately get the MS and the NMOS. Okay. Finally, how would you investigate a patient presenting with a COD syndrome? Again, your take-home message is always consider compressive lesion first, which means you do a MRI. MRI of the relevant region of the spinal cord is your starting point. Now don't ask whole spine. Whole spine, people ask for MRI whole spine are people who do not have brains. People do not have any intelligence because they cannot localize. Now 6 years of medical school, and if you can't localize the lesion, then you really miss the bus. Why is it important to look for a localized lesion? Because when you do the MRI of that localized lesion, you get much more detail. And the likelihood of you missing a lesion is very much less. When you do the whole spine, the details of the MRI is less. It's less sensitive. So you're going to miss the lesion. So that is why I emphasize localize clinically and ask only for the specific region. So that patient coming with a T10 sensory level, you don't need to do cervical spine, you don't need to do lumbosacral spine. You only ask for thoracic spine. Okay. How do you investigate a patient with non-compressive myelopathy? It's based on the 7 categories I've given you. CSF examination, you do virus scan for transverse myelitis, you do MRI brain, I told you, for multiple sclerosis. You do the aquaporin for IgG for NMO. You do the vasculitis screen if you are thinking of SLE, you do ESR, CRP, anti-nuclear antibodies. HIV VDRL for that category of HIV and syphilis. Vitamin B12 levels, full blood count, blood picture because you get macrocytic megaloblastic anemia. And neurophysiology for any associated peripheral neuropathy. So in summary, always consider compressive lesion first in all patients who present with a myelopathy. Identify the cause for non-compressive myelopathy. So once you have localized the lesion, the next step is where is the lesion? Next step is what is the lesion? Go through the 7 causes because the etiology is important. Treatment is based on the etiology. I told you, if you give the treatment we give for multiple sclerosis to NMO, the NMO patient gets worse and becomes completely disabled. And you don't get a second chance. In medicine, you don't get a second chance. You paralyze a patient, the patient remains paralyzed forever. Intravenous steroids are given to reduce cord edema, whatever the cause, whether it's compressive or non-compressive. Say a patient comes with a compressive lesion, until the neurosurgeon can remove the tumor or the hematoma that is pressing on the cord, we give steroids to reduce the edema and the damage, long-term damage to the cord. Okay, we will end with this single best is MCQ to see whether you have understood what I have taught you. So you can read this question and answer the SCQ. I will put the poll up for you. You can move the poll out of the way. There is only one correct answer. Read carefully and answer. It tests your knowledge on anatomy, tests your knowledge on the etiology, it tests your knowledge of whether you have been paying attention in this lecture. 1 minute up and only 10 people have answered. We shall end in 2 minutes. So I shall give you only another minute. You don't get any marks, so just mark it because it just tests your knowledge. You are testing your own knowledge. "30 seconds more. "20 seconds. 15. 10. 5. Okay, we shall end the poll. Only 78 have answered. Okay, so out of 133, only 78 have answered. So that's very poor, really. Only 133 have attended the lecture to start off.
Excuse me, sir.
Yes, dear.
It might be an issue in my device. We can't see the fonts.
Can't hear?
We can't see the poll for some of us.
You can't see the poll.
Or it might be an issue with my device.
Your device. Neither. Because 78 people have answered. So might be a problem with the device that you're using. I think I sent an email to your batch reps to inform you to use a proper device. Otherwise, you're going to miss out on all this. Anyway, let's discuss the answer. So the majority have gone for D, vitamin B12 deficiency. That is 46%. 33% have thought it is C. 4% B. 8% A. 9% E. Okay. Right. So again, I told you epidemiology is important. Old man, 76-year-old man. In a 76-year-old man, you never consider multiple sclerosis. Okay, that's out already. The minute you say 76-year-old man, old man, multiple sclerosis is gone out. So you have only 4 to select from here. Okay. Presented with difficulty walking for 2 weeks. So it's quite a acute, subacute problem. On examination, he had spastic paraparesis. So obviously lower limbs, upper motor neuron sign with extensive plantar response. No sensory loss. Now in vitamin B12 deficiency, we said there is talking sensory loss. We also said there's loss of joint position sense. The majority said B12 deficiency. It says no sensory loss. So it hasn't gone to your head that vitamin B12 is I kept mage. Kela hindenakan kiwa subacute combined degeneration. Dorsal columns are affected. There is loss of joint position sense. Okay, kiwata passe when you say no sensory loss also you select vitamin B12 deficiency. Why joint position sense is not a sensory loss? It is a sensory loss. I also told you in B12 deficiency there is talking sensory loss. So no sensory loss B12 deficiency also goes out of the window. So you are left with only 3. Of the 3 again transverse myelitis there is a sensory level. So we can a sensory loss. So then you are left with only 2. So transverse myelitis also excluded. So this is how you answer MCQs. Not difficult again. But you have to know, your basic knowledge has to be there, because you know multiple sclerosis, with age and sex, multiple sclerosis goes out. With no sensory loss, B12 and transverse myelitis goes out. So you are left with only A and C. Then intrinsic muscles of the hands were wasted with absent bicep jerks and exaggerated tricep jerks. So where is the lesion? If the bicep jerks are absent and tricep jerks are exaggerated, where is the lesion? Anyone? Cranial nerves normal. Where is the lesion? First, always be methodical. Ask yourself, where is the lesion? Next only you ask, what is the lesion? I mean, the question is asking, what is the lesion? It is not asking, where is the lesion? But in your mind, if you know where the lesion is, then you can work out what is the lesion. Anyone? Where exactly is the lesion? Hello? Lamio? Rivi Sarani? Kianda?
C5, C6 level.
Very good. Why? You are correct. Kianda?
Because the bicep jerks are absent and the tricep jerk is exaggerated.
Excellent. Well done. Okay, you are absolutely correct. So that is given then. Bicep jerks are exaggerated. Bicep jerks are absent. Tricep jerks are exaggerated. You know the triceps are C7. So if there's a lesion at C5, C6, that is going to work as an upper motor neuron lesion for the triceps. So you're going to get exaggerated triceps. Whereas biceps are going to be absent because it's at C5, C6 level. Okay, right. So now how do you differentiate? Now in both amyotrophic lateral sclerosis and cervical myelopathy, you get this identical picture. Now it's a bit unfair because still you can work it out, because in amyotrophic lateral sclerosis, it's not an acute problem. It won't occur over 2 weeks. It's a chronic problem. 1 minute. Yeah? Okay. So that you will learn tomorrow when we do the lecture, that amyotrophic lateral sclerosis doesn't occur within 2 weeks. So your correct answer is cervical myelopathy. Right? Did not cervical spondylosis. One of the causes of cervical myelopathy is cervical spondylosis, which is a chronic problem, but there are other causes of cervical myelopathy. All it means is some pathology of the cervical cord. Okay, end of lecture. Any questions?